This is Selma Schimmel in Las Vegas at the Community Oncology Alliance meeting, and now I am joined by Mary Kruczynski, who is the Director of Policy Analysis for COA, which is the Community Oncology Alliance. Hello, Mary.
Hello, how are you?
I'm okay, how are you?
I'm pretty busy today.
I have a feeling you have your hands full with policy issues for 2012 and beyond.
Yes, we do.
Where do we begin?
A lot of issues. Well, the areas that I have been focusing on most recently are oral drug parity. There's a lot of legislation at the state level. The state legislations are very active in many of the 50 states. A lot of movement from the folks and the various advocacy groups up on the Capitol steps of the various states. We're hoping to get oral parity passed, even though the legislation affects only a part of the population. It will not affect the Medicare population, but it will help those who are privately insured to be able to afford their oral cancer drugs. You see, as it stands right now, if a patient is prescribed a medication and it is in an injectable form, it is covered under the medical benefit. If the cancer drug they need is in an oral formulation, it's covered under their pharmacy benefit, assuming they have one. And the out-of-pocket for the patient for an oral drug is far greater than any cost from an injectable. So it's very important that we get patients access to these drugs that are affordable.
Why, I mean, I understand this, and you know, they have specialty pharmacies and you can't fill some of these drugs at your regular pharmacy. You've got to get it done through the insurance carrier's specialty outlet. Why is it, logically it would seem that it's cheaper to be able to take it orally, go home and do it, less personnel involved, you don't go to the doctor's office. Where is that gap? Why is it more costly?
It's more costly because it is an oral drug and it goes through a pharmacy benefit. And typically, any medication that you get under a pharmacy benefit has a copay or a deductible as opposed to the medical benefit. And the fallacy is that an oral drug is simple, that you just go home and take a pill and it's all good. But that's not true at all. Actually, cancer patients taking oral medications are even more difficult to manage than those on an infusible or an injectable therapy.
And I would imagine that is because you've got the compliance and adherence issues, and when you go to the doctor's office, the doctor can monitor, he or she is aware that the patient has taken the meds, patient goes home. So on the flip side, the ease of doing it at home is one thing if the patient is totally compliant, but I believe then it would make sense that it's more challenging within the practice because you never really know what's going on with your patient until you evaluate your patient.
Until you see that patient face to face, you don't really know, correct? Until you do blood work, until you look at them, until you ask them questions. Many times we'd say, are you taking your medication appropriately? And yes, I am. You know, until you actually have that eye contact with the patient, you really don't know the whole story, and that is the fallacy. And there's a standard operating procedure that has to be set up for orals because 35% of the drugs in the cancer pipeline are in an oral formulation. So it'll be very, very important moving forward that we do have coverage parity, because if we don't, patients won't be able to receive the treatments as appropriately, and you're going to find them in the ER.
And with more and more generics coming into place, so if there's a drug that, let's just say 2 weeks ago as an example, was not available generically and the patient had been taking it in its original format, and now it is available generically and the insurance company says, well, now you take it generically, are there issues with when drugs go generic for cancer patients?
In the oral formulation, no, because the orals are very new to market, so you won't see too many generics in the near future. But the injectables and the infusibles, yes, the problem continues to grow. We look at generics and the problems that we have with access moving forward as a problem of price. And cost of supply and demand. When a brand drug goes generic, the price is lower. That's good for you and me because that means it's more affordable for us to achieve that drug. And you've got maybe 5 or 6 manufacturers manufacturing that drug. As time goes on, that price continues to get lower and lower. And the manufacturing facilities still have the same costs associated with the actual making of that product. And cancer drugs have to be made very differently. They're not like popping out of Bayer aspirin. They're a very sterile environment, and a lot of quality metrics have to be met. So they're still continuing to spend the same amount of money to manufacture a drug that becomes less and less profitable for them. And we hate to say that they choose not to manufacture because they're not making money, but like anything else, if your costs aren't covered, you're going to have to close your doors. And so you've gone from somebody that had 6 manufacturers making a new generic drug to a sole source, 1 manufacturer. So it's simple economic supply and demand. And if something happens on that line and it shuts down, then you have nothing, as is the case with one of the brand drugs that we're now going to India to get.
I think that it's a real wake-up call for us when in the United States drugs are unavailable, and some of these drugs are drugs that have been in use for quite a while as stable drugs for serious cancers like ovarian.
And childhood cancers, leukemia. You've got children right now who cannot get cytarabine to basically cure them. It's a curable disease. And it's, if I were a parent of a child, I guarantee you I'd be on the Hill every day until the problem got solved. But it's not a quick solution.
Of the policy issues that you're navigating your way through right now, obviously the drug shortage is at the top. What's next?
So besides oral parity and drug shortages, we're very, very concerned about physician reimbursement because physicians are closing their doors because they can't pay their bills and keep their staff. We see a lot of movement toward the hospital environment from the community practices because they are between a rock and a hard place financially. And they're being wooed to the hospital saying, come work for us, you can be an employee, you won't have any of these headaches, you won't have to worry about electronic medical records, you won't have to worry about e-prescribing, you won't have to worry about a formulary of drugs that you can or cannot afford, and life will be good. So we see this movement back to the hospital when back in the 80s the government said to us, every patient that gets cancer gets admitted as an inpatient and they're there for weeks on end receiving their cancer treatment. We can't afford to keep that going. Oncologists, you need to figure out a way to get the patients out of the hospital and administer that care at a different site of service. Now back then we had about 8 cancer drugs, but oncologists managed to set up a protocol to deliver that chemotherapy outside of the hospital setting. And as time grew and more drugs came to market, they perfected that into where we now have probably the greatest cancer care delivery system in the country. We're seeing it revert back, kind of like miniskirts, to the hospital. And so COA said, this is wrong. Why are we dismantling this system? We recently completed a study comparing the cost of delivering cancer care, total care to a patient diagnosed with cancer, whether that care was delivered in the hospital outpatient setting or whether that care was delivered in the community freestanding practice setting. I can tell you that we went through rounds and rounds of claims that were furnished to us by private payers, which has never been done before. Paid claims with actual dollars expended both by the payer and also by the patient, out-of-pocket, copay, or deductible. Why did they do that? Because payers, insurance companies, know that they're paying up to 5 times the cost for care, cancer care in the hospital setting versus the office setting. They don't want to see their patients, their insured lives rather, our patients being treated in the hospital setting. So they gave us their paid claims so that we could do an analysis via Avalier. And the analysis revealed what we suspected, and that was the cost of delivering cancer care in the hospital outpatient setting far outweighs the cost of delivering care in the freestanding community setting. We hope to use this information as we move back to Washington in the payer space, talking about reimbursement and bridging it to the care model that we're pushing forward, which is the oncology medical home.
Obviously, this is a work in progress, and it's a lengthy process. How do you emotionally keep your energy going through so many real difficulties that you face, a lot of uphill struggles?
They're all uphill struggles. You have to be passionate, you have to love what you do, you have to remember who you're doing it for. You know, when I get into the business of cancer, no one in my family had ever had cancer. So I didn't get into this because I had a previous history. Coincidentally, during the course of my time in this business, I lost both my parents to cancer. And they did get excellent care. And I would like to see that for those that come after them. And certainly 1 in 2 men and 1 in 3 women will have cancer in their lifetime. I believe in what I do. I feel fulfilled in what I do. And I have a passion. And everyone involved in cancer, you have to have a passion. How could you treat people every day and look into their eyes if you didn't passionately care about them?
Oncology is one of the most unique areas of medicine and one of the most rapidly changing areas with the advancements in molecular therapies and understanding the human genome.
Yes, it is. And there's great hope for a cure for cancer someday. Our concern is, will the physicians be here to deliver the cure?
I look forward to meeting with you again to see what is not only happening the remainder of this year, but what's beyond us.
Well, I appreciate you taking the time.
Thank you. Mary Kruczynski, Director of Policy Analysis for the Community Oncology Alliance.